Hello, everyone. I am a little late getting on. Sorry about that. So hopefully I will look for some comments and I'm going to give some people some time to get in. And oh, good. Perfect. Yeah, so I'll give some people some time to get in. And then I think I had an old title, but we had already done the Viagra. So we were really going to talk about who really needs testosterone because that was what was in the community. And then after we'll post, but I think what I want to do next week is actually talk about apomorphine and delayed ejaculation because that seems to be a big topic. And I am planning some other video content of it, but I'm going to go ahead and do that for 2 weeks from now for the live. So we will see how that goes. So basically, when we talk about, and again, as I start to see comments, we'll get into a lot of that as we're talking. So if you have any questions, you go ahead and just drop them in the comments as we go through it. So basically, who does need testosterone? So, and again, there is a great book by Morgenthaler, which is a urologist out of Harvard. That was one of the early ones that was working with testosterone in men and low T and was of the training mindset based on the fact that he was at Harvard. And it was, years ago that testosterone caused prostate cancer, but it didn't logically make sense. And to me, it has to make sense, or I'm not going to believe it necessarily. But if testosterone alone caused prostate cancer, that essentially all young men would have it, and it wouldn't be a disease that is recognized more in older men. So, but still, low T in that book is called Testosterone for Life, is talking about testosterone and symptoms. So basically that you are going to use testosterone optimization if you have symptoms. But it kind of makes sense because if you're not having any symptoms, then why would you need testosterone? You wouldn't have any complaints. It's not like your doctors are just randomly testing to put you on testosterone. They will randomly, or not randomly, but they will test for like high cholesterol, diabetic markers. They're going to check your blood pressure when you go in, but they're not just going to draw a testosterone level and place you on something. So it's diagnosed by not only a number, but by symptoms. And so it's not diagnosed by just one lab number. So true testosterone deficiency means that you have some symptoms related to the number. And so the American Urologic Association uses the total testosterone level of 300 as a reasonable diagnostic cutoff and recommends, that you have, and again, they recommend early morning measurements, potentially. But that's a little harder to do. Testosterone does rise more in the morning. We talked about morning erections. We talked about cardiovascular risk and heart attacks happening more commonly in the morning because of that rise. And so that would make sense. But just like the societies may recommend a 24-hour hormone test for women, sometimes what we recommend academically doesn't work out clinically because patients can't do a continuous blood test. They can't be there first thing in the morning. They can't do 1 or 3 levels before you can actually do testosterone. So it doesn't become realistic if you are of the mindset that you have to have things covered by insurance and to have medical care. If you're going to see a doctor, if you're going to, be treated by a physician, it has to be insurance based. Then again, you may have to go along with all of those guidelines. But if you just want to see a specialist that does hormones, perhaps not. So again, progressive-minded patients typically end up in front of us. We do a lot of remote as well. And so that we can look at the whole picture and treat the man or woman comprehensively. So again, men absolutely need testosterone and can experience major improvements with it. And again, what are some of those things that a man might experience? And we've talked about this multiple times. But again, you could have a low sex drive. You could have some sleep issues. You could have mood. You could have anxiety. You could be experiencing some depression, and erection changes could be part of it. You don't recover the way you used to. You're not building muscle the way you used to. Again, those morning erections are not as frequent or as strong. Your ability to get an erection every time that you need it or want it doesn't happen, or that you aren't consistently holding the erection. It could be low energy. Again, there is brain fog, loss of words. There is lots of different issues that can happen. I say it's a zest for life. And if you're not feeling like yourself, then that is one of the things that you would want to consider is hormones. And so that would be when you would want to get tested, is that you were starting to experiencing something that doesn't seem to be making sense to you, right? And so that is why we would end up doing a testosterone level, doing a hormone evaluation, and then tying it into the symptoms that you might have. And so if you have those symptoms and you have a low testosterone level, and again, we'll talk about what that level is, then those two together in customizing to you and getting you feeling like yourself, that's the goal. And so we want to do the whole picture. You have some symptoms and you have a level that actually makes sense that we would want to optimize. So if, say, a 300 to 950, and it depends on the lab. So something along those lines, like it's 2 something to mid 900s. So that's a large range, right? And so if, for instance, you were 300 and now you're 900, that's a big difference. And so you wouldn't be optimal if you were 400 because you used to be 900 and now you're 400. And so you're less than half of the normal. And so therefore, that wouldn't be normal for you and it wouldn't be optimal. And again, I always say, who wants to be normal? You want to be optimal and not just normal. And so basically, so you want to take that into consideration. Your doctor wants to do that too. They want to know about free versus, a binding globulin, the testosterone that's in the bloodstream. So the total that we're talking about could also mean that it's binding. The binding globulin, the protein, is binding testosterone. And therefore, what's free and what is active is low, and it should be at least 2%. So we want to look at multiple things. But if you just went in and they did a total testosterone and you're, say, 400, but you used to be 900, then that would not be optimal. And so that's where we end up looking at a lot of different things. So basically, when we, and then we're going to tie it back to your symptoms and see what's going to be helpful. And again, if you bind a lot, then maybe we want to make it even higher on that higher end. But 800 to 1100 is typically the range that we are going for when it comes to a man and optimization. So what are some of the things that we might look for when we are actually looking for labs on a regular basis? Because we will do labs every 3 months. And again, drop in the comments how often you get blood drawn when you're on. So if you're on testosterone, I'd love to see how often you get blood drawn with that, because you should really have blood drawn and checked every 3 months. So what are some of the things that you might be looking for? Sorry, I'm messaging about an office issue at the same time. So basically, one of the things that you would want to check, because it could get abnormal, is H&H, hemoglobin and hematocrit, because that actually can go up with treatment. And so you would want to make sure that they're checking that on a regular basis. And we will often do that we don't often, we do it every 3 months to make sure that that doesn't elevate. That's a side effect. So what are some of the other potential side effects that you might have? And some of the other things that might happen is that, again, your testosterone, when we give it, we want it to stay testosterone, but occasionally it can convert. It doesn't occasionally. It does convert to DHT, which is dihydrotestosterone, and then it can convert to estrogen. And we want to have those within a certain range and within normal. So you definitely want to do a baseline of a DHT. That is the one that if it elevates, it's 10 times stronger, but it also can cause side effects. So what are those side effects? Hair and acne changes. It also can cause some prostate changes. And so the prostate can get enlarged. You can have urinary symptoms. So those are why we would obviously test hemoglobin and hematocrit, but you're also testing a PSA to see if that's elevated. That's your prostate specific antigen. And if that actually ends up going up, then you would, again, it would indicate that maybe something's going on with the prostate. Maybe it's enlarging a little bit. And so you would not want that to happen. And then also urinary symptoms would go along with it. And so that is something we would definitely do on a regular basis and every 3 months for sure. And so basically, I want to know in comments, I want you guys to comment to me and tell me, how often are you getting your blood drawn and checked? Because if you're not getting it checked that often, then it's probably not going to be accurate or adequate for you to have good optimization. So one of the questions is, again, frequently, if you are placed on testosterone, does it shut down your own system to testosterone? And it does, like production. So basically, if we give somebody exogenous testosterone, then it could shut down their own system for production of testosterone. And so if fertility is an issue, then you would want to do something else in addition to. And so initially, we would be checking LH and FSH. And so that is something that is released from the brain. So basically, you have your brain that's going to produce LH and FSH, and then it stimulates the testicles to produce testosterone. And so again, I think that sometimes, and there is comments in the chat about, again, once somebody is on those agents to continue the production of their own testosterone, that you will also check LH and FSH in addition to. A lot of times we will have a man on one of those agents because we want to still continue the production of his own testosterone, but we actually aren't as worried about fertility or maintaining, because that's not our specialty, is fertility. So it's not as if we are definitely looking for an elevation of LH and FSH to make sure that they have fertility, but instead we want to make sure that they have production of testosterone still. And a lot of times what we're doing is we're actually putting men on it to help with testicular shrinkage if they have that on testosterone, because again, you're giving exogenous testosterone and it can shut down your own system. So those enclomiphene is like an oral selective estrogen receptor modulator, so a SERM. And so basically it is stimulating the brain hormones and to stimulate the testicles to produce testosterone. So there are a lot of symptoms that you could potentially get with those agents. But what we like to do is, if somebody really feels bad and we want to get them feeling better, then we will start with testosterone first, because we want you to feel better. So we end up putting you on testosterone probably for at least 3 months, maybe 6, depending on how you feel. And so potentially we are looking at it from the standpoint of, I want to get you feeling better. I want you to know what that feels like. And it's definitely not going to be that you have infertility just based on being on testosterone. in shutting down a system. That shutting down of a system is really meant for longer term use. So if I'm going to put somebody on 3 months and I really want them to feel better, that I am going to put them on the testosterone. And then at 3 months, we're going to talk about maybe going down on the testosterone and going up on enclomiphene or clomiphene instead, so that we can just kind of come down on the testosterone, go up on that. Again, whether it is maintaining fertility, it's not that we don't maintain fertility, it's just that we're not treating infertility. So we're not going so high that we're going high so that we can actually, make sure that a man is fertile in checking FSH and LH. It's really just making sure that we're maintaining production and not shutting down his own system. We do check that, but I'm just saying that I don't feel like you would be in the right hands if you're looking for fertility. I'm not going to dose your serum appropriately for that. So basically, and again, I think that somebody was even bringing up that potential of being on one of those serums and maybe noticing a change in fitness or physique after being on it. And I would almost say that, I don't know, there's lots of different side effects you can have. I don't think that I've heard that one. And we're potentially doing, and it's a more selective than clomiphene, less in the way of side effects. But I would say that for the most part, that probably is coming from an estrogen potentially. But I don't know if you were on testosterone as well. And I don't know if you were on testosterone and transitioning over. I think that I just like to put somebody, optimize their testosterone, get them feeling better. They know what that feels like. And then we would end up transitioning them over to an agent that continues their production. That could be HCG, could be enclomiphene or clomiphene. And we can always do another specific. We do have a video that we can link in the description about enclomiphene versus clomiphene. And we can hit that topic again. I really want to do the apomorphine and even oxytocin and the different combination of agents that we can use for compounded agents. And again, compounding pharmacies are amazing just because they help us fill that gap in medicine and give men a more customized approach to whatever they're feeling and whatever they want to see improvement in. And then every 3 months, it seems as if that is kind of the overall. I see a lot of patients that come to us and they're not getting their blood drawn, but every 6 months and even sometimes beyond that. I really do think that there is an abundance of low T clinics around. And I think that those low T clinics are run by business owners and they staff providers, and the providers are doing, what they know, but you really have to specialize in hormone replacement therapy to do it right and to do it at a different level, because there's so many different things that go into it. And I know that there will probably be comments popping up that say that is not the case. And, this is tested and that's tested. There's a lot of rabbit hole stuff that you can go down on Google. But I think that really having somebody that does it on a day in, day out, can customize it to you, make sure you're being managed correctly, make sure your PSA is being checked, your hemoglobin hematocrit. What I feel is that a lot of men are taking it upon themselves to monitor once they get on low T, and they feel like that monitoring is good enough. And because they feel like they know enough. But to me, that's dabbling. You're not the physician and you shouldn't have to worry about it. You should have somebody that is directing that care for you. If you, it doesn't very good, but still I'm reading some of the questions. So I think that there's a lot of things that if you're on testosterone and your testosterone level's good and you still don't feel better, I think that there's a lot of things that you can have tested. Number one, you would want to make sure that they're looking at everything. So is that an estrogen? that is too high because some men feel horrible on a high estrogen, some feel horrible if it's lower. So when you're using a anastrozole or a blocker for that estrogen conversion, the typical range that I'm looking at estrogen is to keep it in that 15 to 45 potentially. And there's a lot of people of the mindset that you don't have to block it at all to because it can go up, it's protective. I will just say that it's probably harder to treat symptoms such as like breast enlargement or man boobs after the fact, right? So you want to monitor it first. If you have breast tenderness, that we want to be addressing that. But some men do like it, and it goes high, and they feel great on it. So it doesn't matter if we let them go high, but that could be something that causes you continued fatigue, or that you don't feel better, or that your erections aren't great, even because estrogen is required for erections. Sometimes some men, and again, it's all male dependent. It depends on the man. It depends on the patient, because sometimes some men, again, require a lot more of it. They feel better on it. The erections are better on it. And sometimes it's the opposite of that. So it could be either. And then I think that there's other things, making sure your free testosterone is adequate enough, because if you're binding, and somebody else had put something in about Tonkat Alley, and again, I like libido stem is an agent that we use that has Tonkat Alley in it, because it basically has other agents in it that can potentially lower your SHBG, increase your free testosterone. And so that's why I prefer that. And so I think that you're always going to know if you're on supplements and you start to feel better, then maybe it's not time to test, because remember, how you feel is dictating a lot of that care. And so if you feel good, it doesn't really matter what your level is if you don't have symptoms. But if you feel bad, it does matter then. And so I think that a lot of times men are looking online and they're trying to figure out what they can do. They'll start some supplements, and knowing what's too much, knowing whether there's resistance with it, if it's safe, like long term. I think supplements are pretty safe, especially if you're doing a medical grade supplement. We use Designs for Health and Metagenics for ours. And I like those two companies. We use other medical grade supplements as well, but those are our two big ones. And I like the Designs for Health libido stem, and that has Tonkat Alley in it. But I think that if you're taking those supplements, they're dosed appropriately. They will say if there's indications, and most of the time they are not putting out a supplement that you can't potentially take on a daily basis. And so, and because they have lots of different ingredients, and supplements are not regulated at all, that it's always best to go with a medical grade supplement for that. And so one of the things that I wanted to get into that you may not get elsewhere, and this is super important, because I was a pharmacist before I was a physician. So a lot of times people don't understand, including my staff and even medical providers. At times they do now, like, because we talk about these things all the time. When you're talking about sub-Q and IM, and people can bring that on, I definitely think that shots should be at least twice a week, because somebody else brought that up, at least twice a week. You could potentially go to a microdosing on a daily basis. And so if you did a microdosing, you could potentially take even though it sounds like a lot because you're doing daily injections, you still are taking it with a smaller needle, and it's sub-Q. And so it really isn't potentially as bad. And again, every other day, every day, we have patients doing just about anything except for once a week, once a month. We don't do that kind of dosing. So they're at least doing twice a week. Sometimes it's every other day, and sometimes it's microdosing on a daily basis. So say if potentially you were doing, like, again, some men will do 200 a week. It's, 100 twice a week. If that was like a standard dose, where you're just taking that dose but dividing it and doing a microdose in a daily. This is all physician directed. This isn't me directing. This is something that your physician would work with you to do. But what I want to say is, when it comes to IM versus sub-Q, the only difference is volume, really. and it depends on what you're injecting. So, for instance, testosterone is an oil. And so that is a harder thing to inject. So it's harder to push when you're injecting it. And so if you do it more subcutaneously or more superficial, the larger the volume, the more you might feel a little deposition of oil underneath the skin, right? It's an oil. Vitamin D is an oil too, so it'd be very similar if we were doing a vitamin D shot. So we want to go into the muscle with that, but it depends on the volume. So sub-Q versus IM, 0.5 is what I use as a cutoff. So if I'm doing 0.5 in a volume or above, I want to stick with muscle because it's a larger volume of 0.5 cc's or above. And so therefore you want to do a longer needle and a bigger needle because it's hard to push. You want to get deeper into the muscle. If you're doing 0.5 or less, potentially if you got more superficial, it's not such a volume that you would feel this deposition of fat or of oil. So you could still massage it. But when you come to other shots that you're doing, so we do vitamin shots, and then we'll put this big needle on that's at least 1 inch for a muscle, but it's a liquid and not an oil. So, in my opinion, if I'm doing vitamin shots myself, and it's not an oil, so it's not harder to push, and it's still 1 cc, so technically above that 0.5 cc's, I would want it in the muscle, but because it's a liquid, it'll push. It's not going to just stick around, and you're not going to have this deposition of an oil. I will still use a smaller needle because I want it more comfortable, and I know it'll push easily. So I may sometimes potentially do a 27 or a 30. I might even do a 30 half inch because it's more comfortable if I got it into the sub Q. That's okay because it's liquid, and if I massage it, it's going to dissipate. And so really sub-Q versus IM is a volume relationship. And so if it's technically 0.5 or above, definitely IM 25 gauge, usually at least, and an inch needle to get into the muscle. Below that, oil is, again, below that is, sorry, sub-Q, and so you could potentially be in the sub-Q with a 0.4 if you're doing it twice a week and just massage it out, or you can still go needle, but there's opportunity to do a microdosing on a daily or every other day where maybe you're doing, 0.1, 0.2, 0.3 cc's, which is less than that 0.5, so you can go in the sub-Q with a smaller needle, so it's more comfortable. So that's just a little trick. And then the other trick that we do in the office for patients, because again, when we are prescribing, even if it's a remote patient that we're doing like a hormone program with, that we will do an adapter. There's an adapter that you can put on the vial that stays in the vial the entire time. So then you're just doing the Luer lock syringe onto the adapter top. World of difference for men. You're not putting an 18 gauge in to drop a large amount of testosterone, and you're not putting an 18 gauge in the vial top over and over and over again, which is actually going to potentially increase your risk of bacteria in the vial. So that way you put a sterile adapter in, and then you just Luer lock the syringe on, and then when you put the syringe on, you can pull it out. It's very easy. And so I think that we definitely have reconstitution videos on YouTube for peptides. It's, again, not going to give you specifics on what kind of peptide or what kind of dosing, because that depends on the amount in the vial, the concentration, what your provider has actually prescribed. But it does show you how to take bacteriostatic water and put it into a vial to turn that powder into a liquid and then draw it up and inject. So that is something that we have that we can actually, you can just look up reconstitution videos on the YouTube and find that, because it's super helpful. So maybe we'll do one that just talks about like that IM needle that we just talked about, IM versus sub-Q, because that seems to be something over and over again in our office. They will still put a 25 gauge. A lot of times, not a lot of times, they do put it on. I just change it out when I'm doing it. And so, because I want a smaller one if it's a liquid. So if it's just something easy to push, even if it's greater than 0.5, I want it more comfortable, especially if I'm doing it for myself. And then just know that peptides, if ever you're on them, are the next level stack that you can do in addition to hormones. And peptides are amino acid sequences that are going to give the body back what it needs to further repair or do something because it's already missing that. And so there's repair peptides like BPC 157. By the way, the FDA did meet on that, but it was an advisory panel to the FDA, and then the FDA makes a final decision on that. And so that is not yet a final decision on which peptides will come back. But with amino acid sequences and peptides, again, we're just able to stack in addition to hormones and optimizing the body. We're able to optimize levels and what the body can do based on stacking peptides in addition to it. So those may be healing peptides. It might be growth hormone peptides, definitely better than growth hormone. It could be tanning peptides. It could be PT141, all kinds of different things. So you guys let me know. I am going to call it a night. It's been a long day. Thank you so much. Somebody had shared that this is one of their favorite podcasts. And so thank you so much. And yes, I love that. The space of freedom. And it is the space of freedom. Willing to deep dive into anything. I don't think that men or women have enough opportunities of places to go and just to ask questions. And so again, sexual wellness is my specialty and my passion, and helping men have better sex, helping women have better sex, having couples have better sex, and just being able to talk about all the different ways we do that. And again, it just depends on where somebody enters the journey of men's wellness or men's health or women's health, that it could be hormones and they're having brain fog or low energy, or it could be that it's erection changes and we start there, but they're not on hormones and we're addressing it. We can stack peptides because that's a next level. We are addressing supplements and PD5 inhibitors, vascular blood flow, nitric oxide, regenerative treatments such as acoustic shockwave for better erections, which, again, we can talk about anytime, tons of videos on there about that regenerative injection, such as a P-shot. There's ProPhoenix at-home acoustic shock waves. There's vacuum erection devices, Venus pumps. We have all kinds of good videos. And next Men's Move Live, though, I do want to talk about apomorphine. And so get any questions together, that and a couple other kind of rare compounded options. But delayed ejaculation seems to be a common complaint, and I think it's really a sensitivity issue ultimately, but there's some other tricks that if you're not in the office and you're not doing all the acoustic or regenerative treatments with us, there's some tricks you can do at home. So hopefully that helps. I hope you guys have a wonderful evening, and it was so nice to connect with you. Thank you.
You're welcome.